all. I'm Dr. Dhanush Anuradha, first year MD trainee attached to Columbus Teaching Hospital, Kalgoorlie. First of all, on behalf of all of the 3 trainees who have attended this conference, I would like to thank sincerely to our College of Hematologists for giving us this great opportunity to participate this event. So today I will be discussing about 2 topics actually. First topic will be myeloproliferative neoplasms including chronic myeloid leukemia. This presentation was initially presented by Dr. David Ross. Ross is a consultant hematologist in SA pathology with clinical appointments at Royal Adelaide Hospital and Flinders Medical Centre in Adelaide. He has research affiliation with the South Australian Health and Medical Research Institute in the Uni-SA Centre for Cancer Biology as well. And his PhD was on the topic of MRD and treatment-free remission in CML. He's the lead clinician for MPN in South Australia, and he has co-authored more than 100 publications in CML, MPN, and other myeloid malignancies. So the learning objectives for this session were describe the safety and efficacy of asciminib for CML in the first and latter lines, review emerging data on additional genomic lesions in CML, review latest data on treatment-free remission, discuss emerging therapies for myelofibrosis, review response assessment in myelofibrosis, review new treatment for polycythemia vera, and discuss issues in diagnosis and prognostic evaluation for younger patients. So regarding newly diagnosed CML, the questions are what is the unmet need and can we do better than second generation TKIs? So there was this abstract with showed excellent early and major molecular responses observed with asciminib treatment for CML-CP. The study's name was ASCEND CML study. The inclusion criteria were CML in CP, aged more than 18 years, good organ function, ECOG 0 to 2, and E13 or 14A2 or E1A2 transcriptions, BCR-ABL transcriptions, and these patients are given asciminib 40 milligram twice daily, and molecular response assessed by quantification of BCR-ABL by 12 months, and major molecular response achieved by the 78% of the patients, and this has been compared with the previous studies with regulated interferon, dasatinib, and nilotinib, the previous studies, and it was equal to pegylated interferon, the ASCEND study, and by 12 months, molecular response of 4.5 achieved by 32% of the patients in this study. So then there was another abstract which showed the impact of mutations in blood cancer related genes on clinical outcomes in chronic myeloid leukemia chronic phase after 2 or more of tyrosine kinase inhibitors. The study's name was ASSEMBLE. Here the key study criteria were adults with CML-CP previously treated with 2 or more TKIs, failure with or intolerance of most recent TKIs. Patients with intolerance of most recent TKIs must have the BCR-ABL more than 0.1% at the screening with no sorry about that. So again to the asciminib trial, ASSEMBLE trial. The key study criteria were adults with CML-CP previously treated with 2 or more of the TKI, failure with or intolerance of most recent TKIs, and the patient with intolerance of most recent TKIs must have BCR-ABL more than 0.1% at screening without T315I or V299L mutations, and the randomization done, and one arm was given asciminib 40 milligram twice daily, and the other arm was given bosutinib 500 milligram once daily, and then the MMR was screened, and about 37.6% patients achieved MMR by 96 weeks with asciminib arm, and the bosutinib arm it was only 15.8%, and 45%, 5.1% patients achieved less than 1% molecular response by 96 weeks, and in the positive arm, it was 19.4% only. So it has shown the superior efficacy of the asciminib compared to the bosutinib arm. And in this same study population, 162 patients were analyzed for mutations, and 162 patients, or the 70% of the patients had another mutations, and 82 out of these 162 patients had 159 mutations in 23 cancer genes. In the asciminib arm, 53 patients out of 110 patients had mutations, and in the bosutinib arm, only 29 patients had these mutations. So I'll be moving to the next slide. So this slide shows the other cancer-related gene mutations in the CML patients who were in this assembled trial. So about 80 patients didn't have any mutations. So about 50 patients, that means 31% of the patients had ASXL1 mutation, and about 17% patients had ABL1 kinase domain mutations other than the usual BCR-ABL1 transcription. So these somatic mutations were associated with increased risk of treatment failure according to this trial, and the treatment failure probability was high with the patients who had mutations rather than the patients who didn't have any mutations. So in summary, genetic variations are associated with adverse outcomes, and the problem is, can genomic risk-adapted approach improve outcome in this first-line treatment of CML in CP? So my next topic is the treatment-free remission update. So there was this abstract about treatment-free remission after nilotinib plus pegylated interferon alpha induction and pegylated interferon alpha maintenance therapy for newly diagnosed CML in CP patients. The trial was named as TIGER. So in this trial, about 717 patients were treated with nilotinib 300 mg BD, and randomization done to add pegylated interferon to alpha 2B and TFR phase after more than 1 year of molecular response 4.0 was done. So here in the beginning of the treatment, months since randomization, cumulative incidence probability for the treatment-free remission was higher in the pegylated interferon added arm, but with the time, the nilotinib arm and the pegylated interferon added arm became the same, the cumulative incidence of probability for the treatment-free remission. However, months after treatment stoppage, the nilotinib and pegylated interferon combined arm had shown molecular relapse-free survival probability high rather than the nilotinib only arm. So so sorry about that. So there has been another abstract about age-related clonal hematopoiesis mutations detected at the time of stopping tyrosine kinase inhibitor therapy predict the achievement of treatment-free remission in patients with CML CP. So 153 patients were monitored in Adelaide. Clonal hemophysis was defined using strict criteria with variable allele frequency equal or more than 2%, and 26 patients had clonal hemophysis at the time of the TFR, that is 17%. So these are the patients who had clonal hemophysis of indetermined uh, 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 these are the patients who had chip, and these are the patients who did not had chip. So the probability of treatment-free remission was higher in the patients who had this clonal hemophysis. So the identified mutations were DNMT3A mutation was commonly identified 48.3%, and TET2 mutations were identified in 15.5%. So then I will be moving for myelofibrosis. So here they have discussed about alternative JAK inhibitors, fedratinib, and mutation-specific approaches, and targeting other additional pathways like using navitoclax, pelabresib, and selinexor. So this abstract shows efficacy and safety of fedratinib in patients with myelofibrosis previously treated with ruxolitinib. Results from phase 3 randomized Freedom 2 study. Here in the study, the key eligibility criteria were age more than 18 years, primary or post PV or post ET-MF, MPN associated myelofibrosis with DIPS more than or equal to intermediate to, and spleen volume more than 450 cubic centimeters, or palpable spleen more than 5 centimeters below the lower costal margin, and platelets more than 50, absolute neutrophil count more than 1, prior treatment with ruxolitinib with peripheral blast less than 5%, and with normal baseline thiamine. So randomization done, and arm 1 was given fedratinib and the arm 2 was given best available therapy. So the best available therapies were 70.1% patients were given ruxolitinib only, 7.5% patients were given ruxolitinib with hydroxyurea, and 10.4% were given hydroxyurea only. So the primary endpoint was spleen volume reduction 35 by 24 weeks. So as you can see in this chart, the patients who were given fedratinib has about 66.3% patients have 50.5% patients actually had reached SVR 35. That means spleen volume reduction 35 by 24 weeks. But the patients who had got best available therapy, other therapies, only 7.5 patients achieved the SVR 35 by 24 weeks. That means this shows the superior efficacy of fedratinib over ruxolitinib only, or other best available therapies. And there were some other newer drugs, newer appearing drugs. The preclinical evaluation of this new drug, INCB160058 drug. It's a novel and potentially disease-modifying therapy for JAK2 V617F mutant myeloproliferative neoplasms. So this drug it binds to JH2 pseudokinase domain, inhibits JAK2 colony formation from primary cells with minimal effect on the white blood cells. And there was this other drug, JNJ 88549968. It's a novel first-in-class CALR mutex CD3 T-cell redirecting antibody for the treatment of myeloproliferative neoplasms. This drug recognizes mutant CALR and engages CD3 T-cells, inducing autologous cytotoxicity against the primary CD34 cells. And there was this other trial, Transform-1 trial. It's a randomized, double-blind, placebo-controlled, multi-center international phase 3 study of navitoclax in combination with ruxolitinib versus ruxolitinib plus placebo in patients with untreated myelofibrosis. So here also, the one arm is given ruxolitinib combined with navitoclax, and the other arm was given ruxolitinib only. Primary endpoint of this study was spleen volume reduction 35 by week 24. It was assessed by MRI or CT scan. And in this trial also you can see that the spleen volume reduction 35 by 24 weeks the navitoclax combined arm showed 63.2% patients who have reached this target, and the ruxolitinib only arm showed only 31.5% response rate. There was this other drug, pelabresib, in combination with ruxolitinib for JAK inhibitor treatment, naive patients with myelofibrosis. Results of the MANIFEST-2 randomized double-blinded phase 3 study. This study also, the population was divided, and the patients were given, one arm was given pelabresib with ruxolitinib, and the other arm was given ruxolitinib with a placebo. And again, fluid volume reduction 35 at 24 weeks was measured. And the pelabresib given arm showed 65.9% patients getting this target response. And on the ruxolitinib only arm, only 35.2% who got this target. And also this pelabresib arm showed total symptom score change from the baseline at 24 weeks minus 15.99 compared to the placebo with ruxolitinib arm only showing minus 14.05 total symptom score reduction. And regarding MF grade, pelabresib and ruxolitinib arm showed 42 improvement in 38.5%, but placebo and ruxolitinib arm only showed 24.2% patients getting the MF grade improvement. And about another drug, selinexor plus ruxolitinib in JAK inhibitor naive patients with myelofibrosis, long-term follow-up from the EXPORT MF034 trial. And this trial is still ongoing. And that also they have done the phase 1A dose escalation and dose expansion, and the phase 3 study is still ongoing. And the selected endpoints at this study also spleen volume reduction 35 and the total symptom score 50 points. So with selinexor also at any point spleen volume reduction 35 was achieved, and the total symptom score 50 at any time was achieved by all these patients. About polycythemia vera and ET updates, there's this abstract about durability of hematocrit control in polycythemia vera with first-in-class hepcidin mimetic rusfertide, 2-year follow-up results from the REVIVE study. So this study shows, compared to the placebo, highly significant efficacy with this rusfertide arm versus the placebo. Percentage of response was 69.2% with all the improvement of these symptoms. And with out of 70 patients, 5 thrombotic events were discovered with this drug. And out of these 5, 2 were discovered in the patients with prior history of thromboembolism, and 3 were discovered in the patients who did not have prior thrombotic events. About this DAHLIA trial, it's a randomized phase 3 trial of interferon alpha versus hydroxyurea in patients with MPN. In this trial, the patients were divided according to the age less than 60 years and more than 60 years. Less than 60 years patients were given pegylated interferon alpha 2A and 2B separately. And for the more than 60 years patients, they have added hydroxyurea as well. So here they have measured the JAK2V617F kinetics by molecular response status at 60 months. So the pegylated interferon alpha given arm showed complete molecular response and partial molecular response mostly compared to the hydroxyurea arm. And about this abstract was about impact of cytoreductive drugs upon outcome in contemporary cohort of adolescents and young adults with essential thrombocythemia and polycythemia vera. These patients were given the available therapies, and thrombosis-free survival and MF-free survival was measured. And regarding the thrombosis-free survival, anagrelide was the anagrelide had the best probability. and second hydroxyurea, and lastly interferon. However, MF-free survival, interferon showed the best probability MF-free for the MF-free survival, and the other ones showed lesser probability. So again, these are the figures of that same trial, and the effects of cytoreductive agents in myelofibrosis-free survival. By 20 years, MF-free survival with interferon was 100%, with hydroxyurea it was 74%, and with anagrelide it was 73%. So here comes the end to my first presentation. So I would like to invite Dr. Tarshini to continue with the second presentation.
Good afternoon, everyone. I will be doing my presentation about lymphoma management. So this is my first presentation is about aggressive B-cell lymphoma management. So this presentation was originally done by Dr. Laurie H. Sen from British Columbia University, Vancouver, Canada. So objectives of this presentation were to consider emerging insights in molecular heterogeneity of patients with aggressive large B-cell lymphoma and discuss emerging therapies for patients with aggressive large B-cell lymphomas and apply evidence-based treatment approaches for patients with aggressive large B-cell lymphoma. So this is what have been done to all these years for aggressive large diffuse large B-cell lymphoma. So R-CHOP was invented, like R-CHOP was came into picture in 2002, and then until 2022, there were no other drug regime superior to R-CHOP. Then in 2022, this POLA R-CHP was found to have increased progression-free survival. So we'll see what is this POLA. It is polatuzumab vedotin. It is an anti-CD79B monoclonal antibody, which has MMAE linked into this antibody. And after binding to CD79B in the B cell, this MMAE is released in the cell, and it causes cell growth arrest and apoptosis. So this is the action of this polatuzumab vedotin. So when POLA is combined with R-CHP, it showed increased progression-free survival in diffuse large B-cell lymphoma. Here, the POLA is combined with R-CHP because vincristine was omitted due to high neurotoxicity with vincristine combined with POLA. So this is the first abstract. This is about the clinical benefit of POLA R-CHP versus R-CHOP in different genetic subtypes beyond the cell of origin in the POLARIX study. So we know about the cell of origin in DLBCL. There's ABC and GCB subtypes, which are molecularly very different from each other. So, and also survival also differ in these two categories. So this is about how is the survival, progression-free survival. In GCB, it has relatively a good survival compared to ABC subtype. So is it so all the time? So that is the question. So GCB is redefined with the dark zone signature. Dark zone signature means the subgroup of these GCB patients have similar molecular signature with the high-grade B-cell lymphoma because they have MYC and BCL2 rearrangements. So even though patients with GCB usually shows a good prognosis compared to ABC subtypes, if they have MYC and BCL2 rearrangements, that leads to a poor outcome. So this double hit signature positivity in the right side graph, it shows patients with GCB and who's having MYC and BCL2 rearrangement. So they have very inferior outcome shown by this red line. Other patients with GCB has relatively a good outcome. And also ABC patients also have relatively a poor outcome. So this is the POLARIX trial, the same trial. So it is about POLA RCHP versus R-CHOP in these different genetic subtypes. So as you can see, the patients who have ABC subtypes shows superior survival with POLA RCHP compared to R-CHOP, but that is not seen in GCB subtype. So, and also the patients dark zone signature positive DLBCL, that means patients with MYC and BCL2 positive, also shows survival advantage with the POLA RCHP compared to R-CHOP. But dark zone signature negative patients shown in the right-hand side curve, they shows superior survival with R-CHOP. So that means that POLA RCHP shows good survival in the patients who have these worse molecular signatures. So let's move on to a case. This is about 66-year-old male with stage 3B DLBCL. So he presented with conspicuous symptoms and PET scan with FDG avid lymph nodes above and below was shown with the bulky abdominal mass. So CT guided core biopsy revealed DLBCL non-GCB subtype. He has hypertension and dyslipidemia, and he is active, physically active patient. So what treatment option would you recommend as for this patient with untreated non-GCB DLBCL? So because it is a non-GCB type, POLA RCHP will give him a good survival advantage. So this is the next abstract that I'm going to present. So it is about 3-year analysis of SUMA-12. So this is about CAR T cell therapy, a study of axicabtagene ciloleucel or axi-cell therapy as first-line therapy in patients with high-risk large B-cell lymphoma. We know usually CAR T cell therapy is indicated in patients who are heavily pretreated and refractory states, but here they have tested this with first-line therapy with high-risk large B-cell lymphoma. So this is how the study was designed. The patients who were occupied in this study, they had high-grade B-cell lymphomas with MYC and BCL2 or BCL6 translocation. And also they had high IPI score. And plus they had also positive interim PET after 2 cycles of anti-CD20s and anthracycline containing agents. So these patients were given this axi-cell and response rates were recorded like this. So overall response rate is shown here with 86% complete response and also 5% partial response. So these patients has responded well to this axi-cell therapy. If we take this survival curve, so progression-free survival also improved in these high-risk patients with axi-cell. Overall survival also shown a good response in this patient. So moving on to BiTE therapy, so bispecific T-cell engagers in lymphoma. So because of these BiTE cells, it is the treatment landscape is changing rapidly for these lymphomas. So 2 CD19 CAR T products are now approved in second line of large B-cell lymphoma. So patients who are ineligible or have refractory disease after CAR T cell therapy, they have very limited options and very poor survival. So then bispecific T-cell engagers have come into the picture, which are approved in third line or further lines in the setting of advanced large B-cell lymphoma. So we'll start with the case. So this is a 60-year-old male with relapsed stage 3B diffuse large B-cell lymphoma. So R-CHOP 6 cycles were given, but he relapsed 6 months later. Then Axicel was given the CAR T cell therapy, but again he progressed 3 months later. So PET showed bulky 10 centimeter retroperitoneal mass. So biopsy was DLBCL GCB subtype, but no mixed rearrangement. So what will you do next? So then, so to think about that, we'll move on to next abstract. So this is about glofitamab monotherapy in relapsed or refractory large B-cell lymphoma patients. So this is a phase 2 study, still in the phase 2. And subgroup analysis in patients with prior chimeric antigen receptor T-cell therapy and by baseline total metabolic tumor volume. So this is the study design. The patients who were included in this study were patients with DLBCL, not otherwise specified, or high-grade B-cell lymphoma patients, so transformed follicular lymphoma, or primary mediastinal B-cell lymphoma patients. So all these patients, they had 2 or more prior therapy containing anti-CD20 antibody or an anthracycline, that means like R-CHOP. So they are heavily pre-treated high-risk patients. They were included in this trial with BiTE therapy, so glofitamab. So this is how the treatment was given. And for mitigations of cytokine release syndrome, they given obinutuzumab, and also they went up in the dosing beginning from a small dose. So they evaluated the primary best response, complete response rate. So as I mentioned before, this is the patient characteristics who were involved in this study. They all are heavily pretreated patients with high risk subtypes of large B-cell lymphomas. So this glofitamab therapy shown high and durable responses in these high-risk patients. So complete response rate in all patients were 40%. And also relapsed refractory setting or transformed follicular lymphoma state, it was 44%. And prior CAR T-cell therapy, complete response rate was 37%. So majority of patients with complete response at end of trial remained progression-free and alive at 18 months after this end of trial. So how is the safety of this glofitamab? So cytokine release syndrome remained the most common adverse effect. It occurred in 64% of patients. But these cytokine release syndrome events were mostly grade 1. So like they had like milder forms of this adverse effect. So fixed duration glofitamab is a good option for relapsed refractory large B-cell lymphoma in 3rd line or further line setting, including patients with prior CAR T-cell therapy. So complete remissions induced by glofitamab are quite durable, including patients with prior CAR T-cell therapy. At a median of 30 months follow-up, median duration of complete response was 22 months among patients with prior CAR T-cell therapy. No new adverse events were observed since the previous analysis, reflecting the tolerability of the fixed duration of glofitamab treatment. So the next abstract is mosunetuzumab plus pola vedotin, which shows a favorable safety profile and efficacy in patients with relapsed refractory large B-cell lymphoma. So with the efficacy of any drug, we should consider about the safety of that drug and the side effect profiles. So this abstract was done to this trial was done to show that. So mosunetuzumab, Mosun it is a CD20, CD3 T cell engaging bispecific antibody, and it redirects T cells to engage and eliminate B cells. And we know about POLA, as I mentioned earlier, polatuzumab, it targets CD79B to deliver this MMAE, so it directly eliminates B cells. So this is how the study was conducted. So for this study, patients with large B-cell lymphoma, DLBCL, high-grade B-cell lymphoma, transformed follicular, and grade 3B4 follicular lymphoma patients were recruited. So they had more than one or more prior lines of therapy. And these patients were ineligible for autologous stem cell transplant also. So as you can see, these patients are also, they are heavily pretreated patients. Even they had CAR T cell therapy and primary refractory diseases. So the response rates were as shown in these graphs. Complete response was seen in 51% of patients, and overall response rate was like 63.3%. So primary efficacy endpoint was achieved with best overall response rate in this trial. So the adverse effects of this therapy was cytokine release syndrome was there, but it is low grade and confined to C1. And the CRS management, they gave corticosteroids, tocilizumab, and in severe cases, single vasopressors was also given. Other adverse events were neurologic manifestations and also peripheral neuropathy and also neutropenia. Serious infections and tumor flares were also noted. But with all these, what was shown was Mosunetuzumab, mosunetuzumab and polatuzumab vedotin combination had a manageable safety profile in patients with relapsed refractory large B-cell lymphoma. So it fixed duration Mosunetuzumab induces durable responses in patients with relapsed refractory large B-cell lymphoma, including those who had prior CAR T cell therapy. And Mosunetuzumab is an outpatient therapy with a manageable safety profile. And Mosunetuzumab also now has been moved into the phase 3 randomized controlled trial. So this is the abstract. Mosun and Pola vedotin demonstrate preliminary efficacy in elderly unfit frail patients with previously untreated diffuse large B-cell lymphoma. So the summary of my presentation is DLBCL is biologically heterogeneous. So R-CHOP has been the empiric standard of care for like 2 decades. So, but Pola-R-CHP improves the progression-free survival compared with R-CHOP, with preferential activity in ABC and ABC, DLBCL, and the GCB types with dark zone signature. So this Pola-R-CHP has shown survival benefit in patients with high-risk molecular characteristics. And bispecific antibodies have emerged as standard care in relapsed refractory DLBCL in third-line settings. So novel targeted and immunotherapy combinations show promise in earlier lines of therapy. So thank you very much. So I will move on to my next presentation, which is about low-grade lymphomas. So this is about low-grade lymphoma, CLL and follicular lymphoma. So this was originally presented in ASH by Dr. Adam Kitai from Ohio State University, USA. So this is about CLL. So I will be discussing about 2 trials, Gaia CLL 14 trial, where venetoclax was compared with immunotherapy in treatment naive CLL patients, and also Bruin study, where pirtobrutinib in relapsed refractory CLL setting. So this is the case about 55-year-old male with treatment naive IGHV mutated trisomy 12 with simple abnormal karyotype CLL, present to discuss treatment options. He was diagnosed in 2017 and he has been on watch and wait, and he has noticed increased fatigue over the past year. So lymphocyte doubling time, that is less than 6 months, his absolute lymphocyte count is now 187. So HbA also has been going towards the lower side. Kidney liver functions. He has lymphadenopathy, measuring largest in 3 centimeter in axilla. His spleen also palpable, but non-tender, and extends 5 centimeter below left costal margin. He prefers time-limited therapy over continuous therapy. He's nervous about his cardiovascular disease as his dad passed due to MI in 67 years of age. So he has diabetes, no other form, and he's recently retired. So what treatment option should be considered for this patient? So we'll discuss about the case after this abstract. So it is about first-line ventricular combinations in CLL. It is a 4-year follow-up from phase 3 Gaia CLL13 trial. So this is the study design of this trial. There were 4 arms where they compared eligibility for this in the participation of this trial was with the treatment naive patient who are fit patients with CLL and no p53 mutation. So they were given chemoimmunotherapy for less than 65 years of age. FCR was given, and more than 65 years BR, benda rituximab was given. And next group given rituximab and venetoclax for fixed duration of 12 months, and other arm obinutuzumab and venetoclax for fixed duration of 12 months, and obinutuzumab, ibrutinib, and venetoclax also given for 12 to 36 months. Then fourth arm. So they want measure these primary endpoints of this trial with undetectable MRD status at 15 months and also progression-free survival. So efficacy of this trial was assessed by the progression-free survival. So as you can see, this obinutuzumab with the triple therapy arm had a good progression-free survival, but the chemoimmunotherapy, FCR or BR, it had poor progression-free survival compared with these 4 arms. So the obinutuzumab and venetoclax and also obinutuzumab and the triple therapy also show superior progression-free survival compared to chemoimmunotherapy and rituximab and venetoclax. And patients with unmutated IGHV have longer progression-free survival compared to this triple therapy compared to obinutuzumab and venetoclax. But there's no overall survival difference was observed between the treatment arms. And the NGS-based MRD detection below 10 to the power 6 further improves risk stratification and can be used for early identification of patients with very long progression-free survival. So there comes a patient, again, 74-year-old male with deletion 17p, complex karyotype CLL, and who was previously treated with acalabrutinib, and now he's progressed and put on venetoclax plus rituximab. After 2 years of treatment, he had taken venetoclax as single agent. Now presents with progressive symptoms, lymphocytosis and cytopenia. So this patient has progressed on both conventional gluten tyrosine kinase inhibitor, acalabrutinib, and also BCL2 inhibitor, venetoclax. So what are your treatment options? So we'll discuss with this abstract. So it is a pirtobrutinib in post covalent gluten tyrosine kinase inhibitors in CLL and SLL. So this is phase 1/2 of RUIN study. So pirtobrutinib is another BTK inhibitor, but it is different from the conventional ones like ibrutinib and acalabrutinib because it is a non-covalent reversible BTK inhibitor which inhibits both wild type and C481 mutant BTK with a good potency. So the covalent BTKs, they inhibit wild type only. So For this study, they selected patients with these very high risk genetic characteristics with BCL2 mutated patients and BTK C481 mutant patients also. So in this BRUIN study, patients with CLL or SLL who had prior BTK inhibitor with covalent BTK inhibitors and some had BCL2 inhibitors, they were naive, and some exposed to BCL2 inhibitors like venetoclax. So these patients were enrolled in this study. For these all patients, pirtobrutinib progression-free survival in these patients with prior gluten kinase inhibitor patients, they showed a median survival of 19.4 progression-free survival. So pirtobrutinib progression-free survival with prior gluten kinase inhibitors with or without prior venetoclax exposure. So that you can see the two curves. One is for the patients who are naive for venetoclax, and other curve is for the patients who have exposed to this venetoclax. So BCL2 naive patients showed a median progression-free survival of 23 months, and this BCL2 inhibitors exposed patients show a median progression-free survival of nearly 16 months. So the safety about this drug, pirtobrutinib safety profile of patients who have received other gluten tyrosine kinase inhibitors, covalent ones. So infections, bruising, rash, arthralgia, hemorrhage, they were the like adverse events of interest. So the severe type of adverse events, which are grade 3 or more, were not that significant in the pirtobrutinib treatment received patients. So the conclusions were, with the median follow-up of 30 months, pirtobrutinib continues to demonstrate clinically meaningful and durable efficacy in heavily pre-treated patients with CLL and SLL who received post-covalent BTK inhibitors. So, and also pirtobrutinib was well tolerated with low rates of discontinuation due to drug-related toxicity among both BCL2 inhibitors naive and also BCL2 inhibitor previously exposed patients. So these results suggest that continuation of BTK pathway inhibition may be an important sequencing approach to consider in the treatment of CLL or SLL. So now what are the treatment options? So if we go to the previous case, what are the treatment options for patients who has progressed on both covalent gluten trinase tyrosine inhibitor and venetoclax? So the answer what they gave was the pirtobrutinib. If pirtobrutinib is not available, then they gave the second option as the covalent BTK inhibitor plus venetoclax. So my last presentation on lymphoma about follicular lymphoma. This is transient follicular lymphoma study where CAR T cell therapy for relapsed refractory follicular lymphoma. So this is about the patient who had in 2021, mid-2021, diagnosed with follicular lymphoma. There was stage 3 disease, and he was treated with bendamustine rituximab, 6 cycles with rituximab maintenance. Then within 18 months, he developed splenomegaly and recurrent BC. So PET scan showed progressive disease with bulky axillary lymph. And the biopsy of lymph node confirmed it is a recurrence of follicular lymphoma and it is not transformation into higher grade. So what is your preferred treatment for this patient? So we'll discuss in the next abstract. So this is about transient follicular lymphoma study, which is a phase 2 study, primary analysis of lisocabtagene maraleucel or as the second line therapy in patients with high risk relapsed or refractory follicular lymphoma. So follicular lymphoma patients with progression of disease within the 24 months from first line therapy have a poor survival. So this is how it is shown. The blue line shows the progression of disease within 24 months, showing very inferior survival in these patients. So there's an unmet need in second line treatment for patients with progression of disease within 24 months. And also, there are therapies approved in third line for follicular lymphoma, like CAR T cell, BiTEs, tazemetostat, and copanlisib. So this is the transient follicular lymphoma study design. The patients who were recruited in this study had they were relapsed refractory follicular lymphoma patients with high MKL criteria as second line, waiting for second line therapy or third line or fourth line therapy. So these are heavily pretreated patients, follicular lymphoma. So they were given this Lysocell or this CAR T cell therapy. So this is how the study was done. So in these patients, as you can see, the complete response was shown in 96% of patients, which was like best response by independent research committee, shown as like 96% in second line follicular lymphoma patients. Also in the survival curve, also it shows that median duration of response shows a higher in second line follicular lymphoma and also third line setting. With a good progression-free survival and overall survival in this Lysocell therapy. So if we go to the side effects of this therapy, cytokine release syndrome and neurological events in patients with Lysocell, if they graded it, but the cytokine release syndrome, there were no higher grades like grade 3 or above in these patients. And also neurological toxicity also, higher grades were very rare. So this Lysocell or this CAR T cell therapy, Lysocell is a potential new second line therapy option in high risk relapsed refractory follicular lymphoma, including patients who had progression of disease in within 24 months of diagnosis and the first treatment. So it resulted in high response in these patients, and these responses observed were durable. And also, what is most importantly, this Lysocell had a very low rates of grade 3 or more cytokine release syndrome or neurologic events. So that is the end of my presentation. Thank you very much.
Good afternoon, everybody. I am Madhusha Vijayatunga, first year MD training clinical hematology from Colombo South Teaching Hospital. My presentation is on transfusion medicine, platelet refractoriness, and hereditary TTP. The original presentation was done by Dr. Erika Wood from Monash University. Diagnosing and managing platelet refractoriness. So the platelet refractoriness is minimal increment of platelet count following a platelet transfusion. When it is less than 10,000 at 1 hour, we take it as platelet refractoriness, which is called the corrected count increment. Predominantly, it's due to non-immune causes, and immune causes accounts for about 20%. Alloimmune, out of immune causes, alloimmune refractoriness is predominantly due to HLA class 1 antibodies, that is HLA A and B. HLA matched antigen negative or cross-matched platelets are preferable in patients with alloimmune refractoriness, but such platelets may be unavailable for patients with high calculated panel reacting antibodies requiring transfusing against donor-specific antibodies. So here they introduce the term antibody mean fluorescent intensity. So they have used antigen beads which are coated with different HLA antigens, and patient serum sample was added to these antigen beads. So when the antigen antibody reaction occurs, there is fluorescent is emitted, and this fluorescent is measured as mean fluorescent intensity. So this mean fluorescent intensity correlates with the antibody titer. So as you can see in this graph, this patient has a large number of HLA antibodies, and the mean fluorescent intensity is measured. So the antibody titer correlates with this mean fluorescent intensity. So the antibody mean fluorescent intensity reflects the amount and binding strength to a single HLA antigen beam. There is wide interlaboratory variability to define the threshold for a positive MFI. It's taken as 500 to 6,000 MFI. So the next study is to explore the effect of permissive mismatching on post-transfusion platelet increments after transfusing in the presence of one or more donor-specific antibodies. So the objective was to identify a cumulative DSA threshold and other factors predictive of failure to achieve platelet corrected count increment. So the cumulative DSA threshold is the sum of DSA MFIs for individual platelet units. And failure to achieve platelet corrected count increment is taken as rise of platelets less than 7,500. The patient population was patients with suspected platelet transfusion refractoriness, that is cumulative panel reactive antibodies more than 50%, or received 3 or more HLA selected platelet transfusions. So they have transfused different types of platelets and compare the corrected count increment. The types of platelet used were HLA matched or antigen negative platelets, any donor platelets which are having any donor specific antibody, and random donor platelets. So as you can see, according to these graphs, they have measured the corrected count increment in different types of platelet transfusion. So HLA 4 out of 4 matched platelets and platelets which have less than 10,000 mean fluorescent intensity has shown corrected count increment more than 7,500, whereas cumulative DSA MFI more than 10,000 platelet has shown suboptimal corrected count increment. Random donor platelets also has shown a fairly acceptable corrected count increment. So corrected count increment is not significantly different from HLA matched or antigen negative platelet transfusions when cumulative DSA MFI is less than 10,000. So the author's conclusions were: study evaluated optimal MFI thresholds of DSAs for permissive mismatch of platelet transfusion. Cumulative DSA MFIs demonstrated dose response effect. Lower the MFIs generated better corrected count increments. Threshold for cumulative DSA MFIs of 10,000 microliters, below which adequate corrected count incremented more than 50% of transfusions overall. Next study is on prevention of bleeding in patients with low platelet counts. According to the current knowledge, tranexamic acid has shown beneficial effects in patients who are having bleeding, and also for prophylaxis where there is high risk of bleeding. But tranexamic acid has not been shown to be beneficial for prophylaxis for cesarean sections or vaginal delivery. Tranexamic acid is widely used in hematology to prevent or treat bleeding in the setting of thrombocytopenia. So the next trial is to evaluate the effect of tranexamic acid to prevent bleeding in patients with hematological malignancies and severe thrombocytopenia. The trial name is TREAT trial. The objective is to evaluate safety and efficacy of tranexamic acid in adults with hematological malignancies and severe thrombocytopenia. Study population was adults with hematological malignancies who were having intensive chemotherapy or hematopoietic stem cell transplantation and expected platelet count less than 10,000 for more than 5 days. So they have divided this population into two groups, and one group was given tranexamic, either oral or IV, and the other group was given placebo. When platelet count is less than 30, until platelet count rises more than 30 or thrombosis, or patient had received 30-day treatment. Prophylactic platelet transfusions were given if platelets dropped below 10 or at clinician's decision. Primary outcome was proportion who died or had bleeding of WHO grade 2 or more from study day 1 to 30. As you can see in this graph, there is no significant difference between the patients who got WHO grade 2 or higher bleeding or death in the two groups, patients who received tranexamic acid or placebo. Further, they have analyzed the data according to the grade of bleeding, and still there was no significant difference between bleeding episodes in the two groups who received placebo or tranexamic acid. So, according to this trial, tranexamic acid, in addition to prophylactic platelet transfusions for hematology patients undergoing intensive therapy, there was no reduction in risk of death or WHO grade 2 or more bleeding up to day 30. Higher proportion of patients surviving to day 30 without red blood cell transfusion. The last study is on diagnosis hereditary TTP. So, as we all know, when there's thrombotic microangiopathy with ADAMTS level activity less than 10%, it's confirmed TTP. And then we do ADAMTS inhibitor or anti-ADAMTS antibody level. If it's positive, it's taken as immune TTP. If it's negative, and the measured ADAMTS activity while the patient is on remission, if it's less than 10%, it is possible congenital TTP, and it's confirmed by ADAMTS 13 sequencing. So next study is on hereditary TTP prophylaxis and treatment. According to the current available knowledge, plasma strategies used for prophylaxis in congenital TTP are FFP, solvent detergent plasma, or plasma-derived factor 8 1 milligram factor concentrate. Half-life of plasma ADAMTS activity is 2.5 to 7 days. According to the recent ISTH 2020 guideline, hereditary TTP in remission, they recommend plasma 10 to 15 milliliter per kg body weight or watch and wait treatment according to the clinical scenario and individualized for the patient's management. And hereditary TTP remission in pregnancy, they recommend plasma therapy. The treatment is burdensome and carry risk. The recombinant ADAMTS 13 is approved by FDA in 2023, and half-life of it is 1 to 4 days. So in the study, they have evaluated the value of prophylactic plasma and incidence of acute episodes in International Hereditary TTP Registry. So the aim was to evaluate prospectively the incidence of acute episodes in hereditary TTP. Hereditary TTP, they have defined as persistent ADAMTS activity less than 10% or biallelic ADAMTS 13 mutation, or infusion trial with full recovery and half-life of plasma ADAMTS 13 maintaining for at least 60 hours. Long-term prophylaxis was defined as at least once a monthly plasma infusion over 6 months. So the result was prophylactic plasma treatment reduced acute TTP episodes in hereditary TTP patients, particularly when used long-term. So as you can see in this graph, they have compared the acute events in hereditary TTP patients who received different types of prophylaxis. The upper part, they have shown the patients who received any type of long-term prophylaxis. Then they have selected the group who are receiving long-term prophylaxis during periods of acute TTP. And further, they have categorized the patients into the frequency of the FFP treatment once weekly, twice weekly, and more than 2 weekly. So, according to the study analysis, the acute episodes were less in patients who were receiving any type of prophylaxis. However, the interval between plasma infusion varied. Prophylaxis reduced incidence of acute TTP. However, 50% patients on prophylaxis still had breakthrough events. So the conclusion of this study was hereditary TTP patients benefit from prophylactic plasma treatment, which was most evident in patients on long-term prophylaxis. However, it is insufficient to suppress residual disease activity, leading to breakthrough events observed in half of the patients on prophylaxis. In the next study, they have evaluated the effect of recombinant ADAMTS13 for treatment of acute TTP events in patients with congenital TTP. It's a randomized controlled trial where one set of patients received prophylactic ADAMTS13 and the other set of patients received a standard treatment, that is FFP, SDFFP or 1 milligram factor concentrate. So the patients who received recombinant ADAMTS13, they have received it until 2 days after resolution. The resolution was taken as platelet count more than 150 or within 20% of baseline and LDH less than 1.5 of the baseline and O less than 1.5 upper limit of normal. So they have analyzed the data. As you can see in these two graphs, the red line indicates the patients who receive recombinant ADAMTS13 and blue line indicates the patients who receive standard treatment. They have measured the platelet increment and ADAMTS activity during the treatment days. So according to the results, the platelet count increment and ADAMTS activity both were showed better results with ADAMTS13 than standard treatment. So over the first 3 treatment days, the mean platelet count increased more than 5-fold with ADAMTS13 and 3-fold with standard treatment. Treatment with ADAMTS13 resulted in rapid increase in ADAMTS13 activity levels to normal range. So the conclusion was the resolution of acute TTP events and improvement in platelet count in patients with congenital TTP following treatment with recombinant ADAMTS13 was closely related to higher ADAMTS13 activity exposure. So the take-home points are platelet transfusion support for individuals with immune platelet transfusion refractoriness with MFI value less than 10,000 will likely result in increased platelet counts. No reduction in WHO grade 2 or more bleeding or death with tranexamic acid prophylaxis in thrombocytopenic patients with hematological malignancy, intensive chemo, hematopoietic stem cell transplant. Plasma-based therapies reduce frequency of clinical events in hereditary TTP, but acute events still occur. That's the end of my presentation. Thank you for listening. Next, Dr. Danshi will proceed with the second presentation.
Thank you, Dr. Madhusha. I will be discussing about acute myeloid leukemia in my second presentation. This presentation was originally presented by Dr. Andrew Wei. He's a professor in clinical hematology, currently attached to the North Health Medical Research Council as a clinical fellow and co-stream lead of acute leukemia and myelodysplastic syndrome at Peter MacCallum Centre and the Royal Melbourne Hospital in Melbourne, Australia. He holds a joint appointment as a Metcalf Family Fellow in laboratory head in the Division of Blood Cells and Blood Cancer at the Walter and Eliza Hall Institute of Medical Research. And Professor Wei has served for more than a decade as chair of Acute Leukemia and MDS Working Party of Australasian Leukemia and Lymphoma Group. And he is an internationally recognized expert in the field of acute myeloid leukemia and has led several clinical trial programs that have contributed to regulatory drug approval and changing clinical practice. So my presentation was based on his original presentation. So the learning objectives of this presentation: upon participation in this activity, attendees will be able to consider new options for assessing and treating older patients with NPM1 mutated AML, and to discuss new approaches for monitoring and treating KMT2A rearrangement AML. So I will be discussing two case scenarios. Case 1, 72-year-old woman presenting with fatigue. Hemoglobin was 9.8, WBC count 2.1 with absolute neutrophil count 0.7 and platelets 85. Bone marrow showed 22% blast with myeloid phenotype and cytogenetics were normal. And in the NGS, NPM1 mutation was positive with FLT3-ITD negative. And ECOG1 with background history of diabetes and anxiety. So the question was whether this patient should be receiving intensive chemotherapy 7+3 or venetoclax azacitidine treatment. So indications for this venetoclax azacitidine therapy are the patients who are too risky to undergo intensive chemotherapy and or patients unlikely to be benefit from intensive chemotherapy. So the patients who are not eligible for the intensive chemotherapy, there are JITMO criteria. And the patients who are unlikely to be benefit from intensive chemotherapy, there are the patients with lower benefit with TP53 mutation and RAS mutation, and so on. There is this abstract which showed intensive chemotherapy followed by oral azacitidine maintenance versus venetoclax plus azacitidine for patients with acute myeloid leukemia. This was a retrospective analysis from EMR database in United States. The patients were analyzed, the patients who have had intensive chemotherapy and consolidation and oral azacitidine maintenance versus patients with venetoclax and azacitidine throughout. So this shows the overall survival rate was higher with intensive chemotherapy with oral azacitidine group rather than the patients who have received venetoclax and azacitidine treatment. Then there has been another study which showed NPM1 mutation with FLT3-ITD negative patients who had oral azacitidine treatment rather than intensive chemotherapy had median overall survival of 48.6% rather than the patients who have received placebo. It was 18.0%. And then the other question occurred whether the patient has to be receiving this intensive chemotherapy or venetoclax azacitidine or 5+2 venetoclax. That means pre-phase 7 days venetoclax and again venetoclax combined with cytarabine and idarubicin. After 7 days of pre-phase venetoclax, patients have shown marked significant reduction of the NPM1 positive blasts. That means less than 0% blast in the bone marrow. And median overall survival in these 5+2+ venetoclax treated patients who are with NPM1 mutated AML showed median overall survival of 43.9 months. And NPM1 mutation clearance after this venetoclax combined treatment with median remission relapse-free survival more than 5 years showed at the end of induction. 35 patients showed undetectable levels of MRD for NPM1 mutation, and end of consolidation 156%, end of consolidation all 75%, and end of venetoclax maintenance 88%. So the overall survival was relapse-free survival was more in the MRD negative patients rather than the MRD positive patients. And these two studies show inferior outcome of the elderly patients who were treated with intensive chemotherapy rather than venetoclax and azacitidine treatment. So more than 65 years of patients saw this reduced probability of overall survival rather than the patients of 55 to 65 years who have received intensive chemotherapy. There are two cohort studies, SWOG cohort and the UK NCRI MRC cohort. Both are showing the inferior outcome of the patients who have received intensive chemotherapy, elderly patients who have received intensive chemotherapy. And with the NGS, the same patient, if the patient was found to have this SRSF2 mutation, is there an adverse risk? So this next abstract shows the secondary type mutations do not impact the favorable outcome of NPM1 mutated acute myeloid leukemia patients, results from a large cohort of intensively treated patients. This shows less than 60 years of patients with secondary type mutations, but initially they have shown survival probability, higher survival probability rather than the patients who had who didn't have secondary type mutations, but with time the survival probability drops, and again same with the patients who are more than 60 years of age. Then we will move on to the second case. It's a 65-year-old woman who presents with fatigue with HB 9.8, total WBC count 2.1, absolute neutrophil count 0.7, and platelet count 85, with bone marrow plus blasts with myeloid type 30%, and cytogenetic showed translocation 611, KMT2A rearrangement, and patient was given intensive chemotherapy with IDAC consolidation, and patient has undergone hematopoietic stem cell transplantation in the complete remission 1. So this abstract showed pre-transplant measurable residual disease detection of KMT2A rearrangement in acute leukemia is strongly associated with inferior post-transplant outcome. So the red line shows the MRD positive patients who are pre-transplant MRD positive patients, and the blue line shows the MRD negative patients. There's a clear relapse-free survival increase in the patients with MRD negative patients, and overall survival also more percentage is more with MRD negative patients at the beginning of the treatment. And the same patients who had undergone hematopoietic stem cell transplantation at complete remission 1 relapses after 84 days. What we will do after this relapse. This study shows revumenib monotherapy in patients with relapsed refractory KMT2A rearrangement acute myeloid leukemia, and revumenib is a menin inhibitor, which will inhibit the menin and stopping it to bind to KMT2A, and then the differentiation and apoptosis of the tumor cells occur. This is the study population, and clinical outcome shows that median overall survival was 8 months who were treated with KMT2A menin inhibitors. And there's this other abstract with first-line human phase 1 study of menin KMT2A inhibitor JNJ75276617 in adult patients with relapsed and refractory acute myeloid leukemia harboring KMT2A or NPM1 aberrations. So this study shows 66 patients were evaluated. 37 patients had KMT2A rearrangement, and 29 patients had NPM1 mutation. And 47 patients out of these patients showed reduction in leukemic burden. And 33 patients, that means 50% of the patients, showed more than 50% reduction of the leukemic burden. This was observed both in KMT2A rearrangement AML and NPM1 mutated AML with this newer drug. And this menin inhibitor monotherapy trial preliminary clinical activity showed 3 out of 6 of complete remission were MRD negative. and 1 responder discontinued for hematopoietic stem cell transplantation, and 2 patients are still in more than 12 cycles, and similar response rates were observed in KMT2A rearrangement and NPM1 AML in this newer drug. So this is the current landscape in AML, and we have talked about this oral azacitidine and 5+2+ venetoclax treatment in the elderly AML, and about the menin inhibitors mainly in this presentation. So there comes the end to my presentation, and I would like to invite Dr. Taishani again for her second presentation.
Thank you, Dhanushi. So I will be presenting about diagnosis and management of venous thromboembolism. So this presentation was originally done by Dr. Mark Carrier, MD, from Ottawa Hospital, Canada. So let's start with the case. So this is about a 54-year-old male with chronic back pain and hypertension, presenting with left lower extremity swelling and pain for 2 days. So ultrasound Doppler confirms acute left femoral DVT. So after discussing risks and benefits of anticoagulation, this patient asked about risk of bleeding with different anticoagulants. And he also asked if he can continue to take NSAIDs, ibuprofen for back pain while on anticoagulation. So this patient has 2 questions. One is the risk of bleeding with different anticoagulation, and also using NSAID with anticoagulation. So what would you recommend regarding use of NSAID with anticoagulation? So these are the preferable answers. So we'll move on to the next 2 abstract and see what can we give, what the advice that we can give for this patient. So this is the first abstract. It is a comparison of bleeding events among patients on apixaban, rivaroxaban, and warfarin for atrial fibrillation and or venous thromboembolism. So this is a retrospective study from 6 warfarin and 4 DOAC registry clinics from Michigan State, US. And so these are so there they have compared apixaban versus rivaroxaban versus warfarin for the patients who have atrial fibrillation or VT, who had more than 3+ months follow-up. So there were 3 arms. They compared apixaban with warfarin, rivaroxaban with warfarin, and apixaban with rivaroxaban. So in this retrospective study, what they observed was, as you can see, rivaroxaban is indicated in blue, warfarin indicated in green. So bleeding rates were higher in patients on rivaroxaban, both major and non-major categories. So as the emergency room visits admission also were high in the patients who are taking rivaroxaban compared to warfarin. So the next assessment, apixaban versus warfarin. So the yellow shows apixaban, green shows warfarin. So the overall bleeding rates were high in both groups, and the patients of apixaban had less major bleeding compared to warfarin. So the next comparison in this retrospective study was the bleeding risk in rivaroxaban versus apixaban. The rivaroxaban is indicated in blue and apixaban indicated in yellow. So the bleeding rates were higher in patients on rivaroxaban compared to apixaban, both major and non-major bleeding, and also the emergency visit and also death rates were high in rivaroxaban, patients using rivaroxaban. So the conclusions, for the patients who are on oral anticoagulation for atrial fibrillation and or venous thromboembolism, bleeding was highest with rivaroxaban, followed by warfarin and then apixaban. Thrombosis were higher in apixaban compared to warfarin, largely driven by other thrombotic events, but similar for other comparisons because this was a retrospective study. There may have been some confounders which couldn't be controlled by the research. And apixaban associated with lower mortality than rivaroxaban and warfarin. These findings reflect what was seen in original clinical trials of these agents, assessing VT and atrial fibrillation outcomes. And also, this retrospective study allowed the comparisons between apixaban and rivaroxaban. The limitation was this was a retrospective study, and the reported events they have taken into account with these clinic registries. So, use of NSAIDs with anticoagulation. So that was the second question of our patient, whether he can use ibuprofen with this anticoagulation. So this study is to see the outcomes of oral anticoagulation with concomitant NSAID use. This is also a registry-based study. So for these patients, 1,796 patients on oral anticoagulation alone were compared with the patients who were taking 449 patients who were getting oral anticoagulants and NSAIDs. So these patient characteristics were matched in both arms. So these are the results. So if you see the thrombosis and the bleeding both in the patients who are taking oral anticoagulation alone and oral anticoagulation with NSAID, didn't show that much of a difference. So the results were not significantly different for both groups. So nearly 4% of patients are taking NSAID with oral anticoagulation. In this propensity match study, bleeding and thrombotic outcomes were similar with and without NSAID. The study limitations were that NSAID use and gastroprotection were only reliably known at the time of study enrollment. So we don't know the amount of time that patient has been or has not been on gastroprotection while he or she was on NSAID. And also the dose and duration of NSAID use could not be adequately understood in this study. So there is a need of further research to determine whether there is a safe level of NSAID use for patients who are on anticoagulation. And also, they explore the utility of gastrointestinal prophylaxis in these patients to reduce bleeding. So if we are going to ask the question of our patient, so what would you recommend regarding use of NSAID with anticoagulation? Yes, he can use ibuprofen sparingly because we don't know what is the safe dose of NSAID to be used with anticoagulation yet. So the next abstract, disease risk factors associated with anticoagulant-related bleeding in patients with cancer-associated thrombosis. So this is also about the patients with cancer-associated thrombosis, and who they have a high risk of recurrence of VTE as well as high risk of bleeding. So there are some bleeding risk models, but they are not. They doesn't show that much of a predictive performance for anticoagulant-related bleeding in patients with cancer. So this is the aim is to evaluate both the association of candidate traditional and cancer-specific risk factors with anticoagulant-related bleeding. So for this study, what they used were the records of US veterans with active cancer and a new diagnosis of VTE who started anticoagulation between 2012 and 2020. So according to the aim of this study, the traditional and cancer-specific variables associated with anticoagulation-related bleeding were identified. So the traditional variables associated with anticoagulation-related bleeding in cancer-associated thrombotic patients were age, with the increasing age, history of plasma bleeding, and also deteriorated renal function, anemia, less than 10 of molar, uncontrolled hypertension, antiplatelet therapy, alcohol abuse, history of stroke, liver disease, and fall predisposition. Cancer-specific variables associated with anticoagulation-related bleeding were metastatic disease, GI cancers, non-prostate GU cancer, and chemotherapy use. So we'll move on to the next case. So this is about a 68-year-old man with metabolic syndrome and also cirrhosis with portal hypertension, presented with 2 weeks history of right upper quadrant abdominal pain. So imaging studies revealed a portal vein thrombosis, and he was started on anticoagulation with therapeutic apixaban. Patient was referred due to concern for bleeding. Full blood count shows a normal white count hemoglobin, mildly low platelet count of 112,000. Creatinine and liver function panel were known. So what would you recommend regarding further management and duration of anticoagulation? So this discussion is based on ASH annual meeting education program session, how to manage splanchnic vein thrombosis in patients with liver disease. So factors associated with splanchnic vein thrombosis, we know that. So there are local risk factors and systemic risk factors. From the local risk factors, liver cirrhosis plays a major role. Others are solid abdominal cancers, infection, inflammatory bowel disease, abdominal surgery, and abdominal trauma. Systemic risk factors are mild proliferative neoplasms, other malignancies in hematological malignancy, antiphospholipid syndrome, inherited trauma, hormonal therapy, pregnancy, paroxysmal nocturnal hemoglobinuria, or autoimmune disease. So these guidelines published by several hematological and also gastrointestinal associations are for the treatment of splanchnic vein thrombosis in cirrhosis. So as a summary, the indication of anticoagulation, what they have mentioned is usually in involvement of portal vein thrombosis and also with intestinal ischemia. In ISTH guidelines, they suggest splanchnic vein thrombosis and no active bleeding or other contraindications should go with anticoagulation. So when should we start this anticoagulation? So according to these several guidelines, as soon as possible or without delay, if there's no bleeding, we should start anticoagulation. And the choice of anticoagulation is was with unfractionated heparin or low molecular weight heparin, BTA, and DOAC should be used cautiously. But DOAC also recommended by these several associations. And the duration of anticoagulation, usually at least 3 to 6 months. And it should be indefinite as suggested by some associations such as ISTH and the risk factors persist, that means cirrhosis persists, or the patient is awaiting liver transplant because portal vein thrombosis will give inferior outcome in liver transplant if recanalization has not occurred properly. So anticoagulant therapy for splanchnic vein thrombosis, it increased with anticoagulation. This is untreated patients are shown in untreated patients are shown in yellow line, and anticoagulation is shown in red color. So as you can see, the vein recanalization increased with anticoagulation, and also recurrent thrombosis is prevented, and decreased all cause of mortality, and also increased recanalization states also seen. And major bleeding episodes are also reduced in patients who are getting anticoagulation. That should be due to the reduced portal vein pressure, increased portal vein pressure, which will be reduced with anticoagulation. So the summary is anticoagulation effectively improves recanalization, reduces thrombosis, progression, and long-term bleeding complications and mortality in cirrhosis. So low molecular weight heparin is the standard treatment in acute case and in the long term in selected case. Unfractionated heparin use limited to patients with severe renal failure or urgent invasive procedure. TIPS or transtubular intrahepatic portosystemic shunts may be considered in patients who have complications of portal hypertension such as variceal bleeding, recurrent ascites, or PVT progression despite anticoagulation. Anticoagulation for at least 3 to 6 months and consider indefinite treatment based on risk-benefit evaluation. BK or DOAC for the long-term treatment. The problem with BK is the monitoring difficult when the INR is also prolonged in the baseline, the cirrhotic patient. And DOACs are contraindicated in child C. And edoxaban and rivaroxaban are contraindicated in child B. So, about our case discussion, this patient, 68-year-old patient with cirrhosis and metabolic syndrome, presenting with right upper quadrant abdominal pain. So he had a portal vein thrombosis. So he was started on therapeutic anticoagulation with apixaban. So after 1 week of 10 mg BD, patient was treated with 5 mg BD for 6 months, after which indefinite anticoagulation was recommended due to continued risk factors for recurrent VTE, and the patient was tolerating anticoagulation without bleeding episode. So moving on to the next abstract with the case. So this patient is a 62-year-old man with obesity, dyslipidemia, COPD, diabetes, presenting to a primary care physician with 2 weeks of right lower extremity pain and swelling. He had an injury 4 weeks ago and sustained a meniscal tear. However, he has been ambulatory and denies any periods of prolonged immobilization. Ultrasound Doppler shows a right femoral deviation, and he was started on therapeutic apixaban. Patient was referred to your clinic for further recommendation on duration of anticoagulation. So, what would you recommend regarding duration of anticoagulation? To find this answer, let's move on to the next abstract. Actually, this was ASH annual meeting education program session article, provoked versus minimally provoked versus unprovoked VT. Does it matter? So I have shown here the risk factors and predisposing conditions for venous thromboembolism. We all know this chart. There are major transient risk factors, major persistent risk factors, minor transient risk factors, and minor persistent risk factors in the categories of surgical or non-surgical, which we take as risk factors for predisposing conditions in venous thromboembolism. Besides them, there are predisposing conditions which are non-surgical, which can predispose for VTE, like increasing age, obesity, heart failure, or prior VTE. So current guidelines on venous thromboembolism, recommendations on secondary prevention. These are adapted from several hematological societies. So for unprovoked DVTs, as we all know, they suggest for the extended anticoagulation. And for the transient risk factors, for the major transient risk factors, the discontinuation of oral anticoagulation recommended after 3 usually. And so for the major transient risk factors, they are against offering extended phase anticoagulation. But persistent risk factors, you should give continuous anticoagulation. So minor transient risk factors, usually extended anticoagulation is not offered. So there was a study where the venous thromboembolism recurrence, cumulative incidence of VT recurrence was assessed with the provoking factors. So the first VTE, when the patient had with the weak provoking risk factor, the recurrence rates were higher. This, the first line shows the weak risk factor. And unprovoked patients with index VT with the unprovoked risk factor, unprovoked VTs, they also had a higher risk recurrence rate. But these, the unprovoked and the weak provoking factor containing index VTs, these patients had high risk of recurrence. So risk of recurrent VT is very low in the provoked major transient risk factors such as surgery and trauma. In unprovoked patients also, risk of recurrence was high. And the risk of recurrence with VT provoked by minor transient or minor persistent risk factors is comparable that with unprovoked VT. So there's a question whether minor risk factors, is that categorization still valid? Or do we need better definitions of what consists of a provoked VT, which reflects recurrence risk and help us guide the clinical practice? So the summary of this article was with the patients treated for an index VT for whom there was clinical equipoise regarding the need for continued anticoagulation. Prophylactic doses of apixaban reduce the risk of recurrence VT by an extent similar to therapeutic dose with a promising safety profile. Risk of recurrent VTE was significantly lower with rivaroxaban at either a treatment or a prophylactic dose than with aspirin, without a significant increase in bleeding rate. This was shown in Einstein choice study. Reduced doses of rivaroxaban and apixaban represent the regime of choice for secondary prevention of VTE in the majority of non-cancer patients for their efficacy to safety profile. But in these studies, the limitation was the patients with high risk of recurrence were not included in these studies, where the reduced doses of rivaroxaban and apixaban has been shown a good recurrence-free interval in other low-risk patients. So if we take our question about the patient who had a meniscal tear and VTE, so what he had was minimal minor risk factors. So 6 months of therapeutic anticoagulation followed by risk-benefit evaluation and low-dose anticoagulation technique is suggested for this patient. So thank you very much for listening to my presentation. So I will hand over to Madhusha for the last presentation. Thank you.
Thank you, Dr. Darshini. So today's last presentation is on management of myeloma. The original presentation was done by Dr. P.Jo Ho from Royal Prince Alfred Hospital and University, Sydney, Australia. I'm moving to a case. This is regarding a 62-year-old man presented with back pain and diagnosed with multiple myeloma with compression fractures and anemia. However, he did not have renal impairment and his calcium levels were normal. Bone marrow plasma cell percentage was 50% and he had translocation 1114, which is a standard risk cytogenetic abnormality. And his CT skeletal survey showed multiple lytic lesions and compression fractures in T12 and L1. He had a background history of hypertension and dyslipidemia. The question is, what induction chemotherapy would you recommend for this patient, assuming there is access to all therapies listed? VRD, Dara-VRD, KRD, Dara-RD, or other? The answer will be discussed in the next few slides. This study is a phase 3 randomized study of daratumumab, which is anti-CD38 monoclonal antibody with bortezomib, lenalidomide, and dexamethasone versus VRD alone in patients with newly diagnosed multiple myeloma who are eligible for autologous stem cell transplantation. The trial is Perseus trial. Here, the eligible criteria of patients were transplant eligible newly diagnosed myeloma patients between age 18 to 70 with the ECOG state of 2 or less. So it's a randomized controlled trial, and in one arm, one set of patients were given induction chemotherapy with VRD, followed by autologous stem cell transplantation, then VRD consolidation and maintenance with lenalidomide. The other arm, the patients were given DVRD quadruple therapy and autologous stem cell transplantation followed by DVRD consolidation, and they were initially given maintenance with dara-lenalidomide, and then MRD status was measured, and the MRD positive patients were continued with DR until progressive disease, and MRD negative patients were discontinued Dara therapy only. Primary endpoint of the study was progression-free survival. In both groups of the patients who received DVRD and VRD, demographic characteristics and clinical characteristics were balanced. So the age, ECOG status, criteria present at diagnosis, ISS stage, and cytogenetic profile were balanced in both groups. They have monitored the progression-free survival. As you can see, the mean progression-free survival at 48 months is significantly higher in the patients who received Dara-VRD compared to the patients who received BRD therapy. Further, they have analyzed the progression-free survival in different subgroups according to age, sex, race, ISS stage, type of myeloma, and cytogenetic risk groups. So in all the groups, the progression-free survival was better with Dara-VRD compared to VRD. So complete response rate was significantly higher in the population who received VRD than the patients who received triple therapy. They have monitored the MRD status throughout a period of time. So sustained MRD negativity even more than 12 months seen in the patients who received DVRD. The safety profile of two regimes, when we consider the safety profile of two regimes, Dara-VRD increase in grade 3 and 4 infections were seen, but no difference in fatal infections. So summary of this first year study, Dara-VRD induction followed by autologous stem cell transplantation and Dara-VRD consolidation and Dara-Len maintenance significantly improves the progression-free survival, complete response rates, and MRD negativity rates compared with VRD induction, autologous stem cell transplantation, VRD consolidation, and lenalidomide maintenance. Benefits were seen across subgroups. Safety profile of Dara-VRD consistent with non-safety profile of VRD and Dara-Len. Moving on to the next trial. This is a result of the phase 3 randomized ISKIA trial. Here, isatuximab, carfilzomib, lenalidomide, dexamethasone versus carfilzomib, lenalidomide, dexamethasone as pre-transplant induction and post-transplant consolidation in newly diagnosed multiple myeloma patients were studied. Isatuximab is a monoclonal antibody targeting CD38. Carfilzomib is a proteasome inhibitor. So in this ISKIA trial, eligible criteria of the patients were transplant eligible, newly diagnosed myeloma patients less than 70 years. In the one arm, the patients were received 4 cycles of KRD and then underwent autologous stem cell transplantation and post-transplant consolidation with KRD. Other arm, induction chemotherapy was given with isatuximab KRD, then autologous stem cell transplantation followed by consolidation. Primary endpoint of the trial was MRD negativity monitored by NGS after post-transplant consolidation. Secondary endpoints were MRD negativity after induction. So in this trial also, patient characteristic, demographic data, and clinical characteristics were balancing the two groups who received quadruple therapy and triple therapy. So the primary endpoint where they monitored the MRD status. As you can see, MRD status measured by NGS shows a better progression-free survival in the group who received quadruple therapy with ISA-KRD compared to the patients who received KRD. Further, they have monitored MRD status at different stages of the study, post-induction, post-transplantation, and post-consolidation. So there is improved MRD negativity over the time in the patients who received ISA-KRD compared to the patient who received triple therapy. Regarding the safety analysis, both the groups have increased incidence of cardiac disorders and venous thromboembolism, which are known side effects of carfilzomib. So summary of this ISKIA trial, quadruple therapy with ISAK-ARD significantly increased post-transplant consolidation MRD as compared with KRD, including in high-risk cytogenetic groups. ISAK-ARD significantly increased MRD after each treatment phase. No new toxicity signals with ISAK-ARD and toxicity profile similar to prior reports. Patient selection is important in carfilzomib-based therapy given the higher risk of cardiac toxicity and thromboembolism. Longer follow-up was needed to explore relationship between MRD negativity and progression-free survival and overall survival because this study was done in a short period of time. The next part of the presentation is on CAR-T therapy in myeloma. In myeloma, CAR-T therapy is mainly targeted on BCMA, which is the bone cell maturation antigen, and the currently available most popular regimes are idacaptogene and ciltacabtagene, which targets different domains of the bone cell maturation antigen. Other than CAR-T therapy, there are other types of therapies which target this bone cell maturation antigen, like bispecific antibody, which is teclistamab, and antibody drug conjugates. CAR-T therapy in early relapse of myeloma, this was studied in two popular trials, which are KarMMa trial, which studied the effect of ida-cel, CARTITUDE-4 trial, which studied the effect of cilta-cel. So here they have, in KarMMa-3 trial, they have studied the effect of earlier line use of CAR-T therapy ida-cel. Here, the population of patients were myeloma patients with 2 to 4 prior lines of therapy. And this is a randomized controlled study. One population received ida-cel, the other one received standard treatment, and they were followed up. And primary endpoint was progression-free survival. As you can see, in the graph and the table, the population of patients who received ida-cel therapy has a significant overall response rate and progression-free survival compared to the patients who receive standard treatment. And in CARTITUDE-4 trial, they have studied the effect of earlier use of CAR-T therapy cilta-cel. Here, earlier line compared to KarMMa-3 trial was used. Myeloma patients with 1 to 3 prior lines of therapy, and one group of patients received cilta-cel, other group of patients received standard treatment, darapomdexor, pombortezomib, dexamethasone, and patients were followed up till the primary endpoint, that is progression-free survival. In this study also, as you can see, the progression-free survival and overall response rate is better with the patients who receive CAR-T therapy cilta-cel compared to the standard treatment. Then this is about the updated analysis from KarMMa-3 trial. Here, ida-cel treatment was compared with the standard regimen in patients with triple class exposed relapse and refractory multiple myeloma. As you can see, these triple class exposed relapse and refractory myeloma patients were given ida-cel treatment, and the progression-free survival was measured. And at 18 months, they have shown higher progression-free survival compared to the patients who receive standard treatment. The phase 2 CARTITUDE trial, this is an updated efficacy and safety of cilta-cel in patients with multiple myeloma, and they have studied two groups. The cohort 1A is 1 to 3 prior patients who received 1 to 3 prior lines of therapy, and cohort B is patients who had earlier relapse after first line treatment. So in cohort A patients, that is patients who receive 1 to 3 prior lines of treatment, They were given Citacel treatment and followed up for a longer time. So, as you can see in this graph, more than 90% of patients have shown a complete response with Citacel treatment and better progression-free survival. At 24 months, 75% of patients have shown progression-free survival. In the cohort B, Citacel was given in early relapse, that is less than 12 months after first-line treatment. That population of patients also shown better complete response rate, that is more than 89.5% of patients has shown complete response, and 24 months progression-free survival rate was 73.3% with Citacel therapy. So summary of CAR-T therapy in earlier line of myeloma, Idacel and Citacel was FDA approved after 4 prior lines and in EU after 3 prior lines, have been evaluated in earlier lines in these studies. Idacel shows improved progression-free survival and overall survival after adjusting for crossover in earlier line use compared to standard of care. This is the updated KarMMa-3 trial. And Citacel shows durable response and 2-year progression-free survival of 75% in 1 to 3 prior lines of therapy in small cohort in CARTITUDE-2 cohort A. Here, patients were followed up for a longer time than CARTITUDE-4 trial. In a small cohort of patients who relapsed less than 12 months after initial therapy, Citacel has shown higher level and durable response with 2-year progression-free survival of 73%. This is the CARTITUDE-2 trial, cohort B. CAR-T therapy in myeloma is usually targeted on bone cell maturation antigen, but there are new emerging targets for CAR-T therapy in myeloma. So there are several other antigens explained in this picture, which are used in CAR-T therapy. So the next study is on new immune therapy in late relapse. A G protein coupled receptor class C group 5 member D, GPRC5D. It's another antigen like bone cell maturation antigen, which are used for CAR-T therapy in myeloma. So in this study, GPR5D targeted CAR-T cell therapy for relapse and refractory multiple myeloma is studied. This is an updated result from phase 1 study. So as you can see, this is still an ongoing trial, and according to the current available data, 86% of MRD evaluable patients with complete response or more is achieved MRD negativity with this newer CAR-T therapy. As this GPRC5D receptor is located not only in plasma cells but also in other keratinized tissues, GPRC5D related on-target off-tumor skin and oral toxicity is seen. So, as you can see in these pictures, there is skin toxicity and oral toxicity. This GPRC5D receptor is used for bispecific antibodies also. The name of the drug is tacrolitamab. With the longer exposure for that with tacrolitamab, there is skin toxicity, which needs topical or systemic steroids. This slide shows the real-world outcome with Idacel CAR-T therapy in relapse and refractory multiple myeloma. So overall response rate, VGPR, complete response, and progression-free survival shows comparable successful data with in the real-world evidence also as in the trial data. Next two disclosures are real-world safety and efficacy of teclistamab, which is a bispecific antibody targeting bone cell maturation antigen for patients with heavily pretreated relapsed refractory myeloma, and teclistamab in relapsed refractory multiple myeloma, multi-industrial real-world study. As I said, teclistamab is a bispecific antibody targeting bone cell maturation antigen. So real-world data with teclistamab also shown better overall survival and progression-free survival as found in the trial data. However, there is increased risk of infection with teclistamab. So primary IVIG prophylaxis is given to these patients who are on teclistamab, and there has been significant reduction in grade 3 infections patients who receive primary IVIG prophylaxis. So in summary, newer targets for immunotherapy in multiple myeloma includes GPRC5D for CAR-T as well as bispecifics. Responses seen in patients who had prior exposure to bone cell maturation antigen targeted agents. Unique on-target off-tumor effects with GPRC5D, that is skin, nail, and oral toxicity, is less in CAR-T cell therapy compared with bispecifics. Real-world data on immune therapy comparable in efficacy, including data on patients non-eligible for clinical trials like patients with comorbidities and organ dysfunction. So summary of the presentation: strong data to support quadruple therapy as standard of care in transplant-eligible, newly diagnosed myeloma patients. CAR-T therapy is moving to earlier lines, and trials have shown improved progression-free survival, overall survival signal with ida-cel shown by accounting for crossover. Newer options for immune therapy like new CAR-T targets and novel agent therapy in relapsed myeloma is studied. Immune therapy in real world has similar safety and effectiveness compared with trials. Thank you for listening.